In the last lecture we have discussed the thyroid anatomy, physiology, embryology, and laboratory assessment of the thyroid gland disorders, and we discussed hypothyroidism, the causes, the clinical feature, and the biochemical aspects of the problem, the diagnosis and the treatment. And we have stressed at the end of the previous lecture on myxedema coma. It's as an emergency case, life-threatening problem, medical problem, and we have to deal with it energetically. And we mentioned the main lines of therapy. Today we will concentrate on hyperthyroidism. Hyperthyroidism is not synonymous of thyrotoxicosis. Thyrotoxicosis means elevated thyroxine hormone, not necessarily associated with hyperfunctioning or hyperthyroid. So hyperthyroidism means elevated thyroid hormone plus hyperfunctioning status. So it is different. Hyperthyroidism is a common clinical problem worldwide, and it is etiologically related to 60 to 80% of cases as a Graves' disease. So classification of hyperthyroidism according to etiology into hyperthyrotoxicosis plus hyperthyroidism, or a primary hyperthyroidism includes Graves' disease, toxic multinodular goiter, and toxic adenoma or hyperfunctioning thyroid nodule, then stroma ovarii, and then drug-induced like amidaron or caldoron hyperthyroidism. There is another entity, thyrotoxicosis, and not associated with hyperthyroidism. So thyrotoxicosis without hyperthyroidism includes thyrotoxicosis factitia. Factitia means self-administration or self-intake of thyroxine, as those people who want to be rejected from military services أيام القادسية كانوا يسوون هيك زين عيني. And the other causes of thyrotoxicosis without thyroiditis, and radioiodine thyroiditis, silent, subacute, all cases of thyroiditis. And in these there is thyrotoxicosis, but the radioactive iodine uptake is low. So to differentiate between the first entity and second entity, I mean thyrotoxicosis plus hyperthyroidism, and thyrotoxicosis only without hyperthyroidism is radioiodine uptake. In the first entity, radioiodine uptake will be elevated, high uptake, and the second there will be normal radioactive iodine uptake. So this is to differentiate. So what is meant by hyperthyroidism is a condition in which an overactive thyroid gland, there is hyperplastic gland, hyperfunctioning thyroid gland, producing excessive amount of thyroid hormones that circulate in the blood. Thyrotoxicosis is a toxic condition that is caused by an excess of thyroid hormones from any cause, not as necessarily associated with hyperactivity of the thyroid gland. It may be self-intake, as I mentioned, it may be thyroiditis, it may be other causes. You see, thyrotoxicosis can be caused by an excessive intake of thyroid hormone or by overproduction of thyroid hormones by thyroid gland itself. Because both physicians and patients often use these words interchangeably, we will take some liberty by using the term hyperthyroidism throughout this article. So our talk, when we mention hyperthyroidism, we will mean thyrotoxicosis plus hyperactivity of the thyroid gland itself. Next. Etiologically, hyperthyroidism may be related to Graves' disease, or and the cause will be functioning adenoma, thyroid nodule, as I have mentioned, toxic multinodular goiter or toxic adenoma, excessive intake of thyroid hormones, abnormal secretion of TSH, as in patients with thyroiditis, excessive iodine uptake. Iodine intake per se may induce hypothyroidism, as I have mentioned in previous lecture, Wolf check-off phenomenon. And radioiodine or iodine itself, iodine intake may induce Graves' disease or hyperthyroidism, as this is a well-known phenomenon, جود بسيدو phenomenon. فإذا اللي ياخذ يود بكميات غزيرة يصير به لو هايبو لو hyperthyroidism. الهايبو يسموها Wolf check-off phenomenon. الهايبر أو Graves' disease يسموها جود بسيدو phenomenon. Okay? Now, Graves' disease, let us concentrate on Graves' disease. What is a Graves' disease? It means thyrotoxicosis associated with hyperthyrotoxicosis زائد hyperthyroidism plus diffuse nodular goiter, and it is firm in consistency and highly vascular thyroid gland. Okay? So goiter, diffuse goiter, in nature diffuse goiter, firm in consistency, highly vascular. Second, thyrotoxicosis plus hyperthyroidism. Third, dermopathy. Fourth, ophthalmopathy. Two or among three. Okay? Will give you the diagnosis of Graves' disease. The Graves' disease is an autoimmune disease, and it is the most common cause of hyperthyroidism. 60 to 80% of hyperthyroidism is related to Graves' disease. So how big the percentage is? Second, it occurs more in female than male, sex predominance, female. Third, 5%, 2% prevalence in females, and 1/10 in male. Age, as regard age predominance, rarely in children, rarely in adult, commonly in the mid-age group, young and to middle age group, 30 to 50 years, the age of predilection. افتهمنا؟ الادولسنت قليل بها، children قليل، كبار قليل، rare. يبقى عندك الايج انسيدنس preferable age incidence 30 إلى 40 سنة. Now, pathogenesis of the disease includes genetic factor plus environmental factor. شنو الكلو للجينيتك فاكتور وشنو الكلو للانفيرومنتال فاكتور؟ الجينيتك فاكتور شافوا HLA-DR polymorphism abnormality، وهاي استنتجوها من الإيفيدنسز التالي. First evidence شافوا الكونكوردنس rate of Graves' disease in monozygotic twin high percent, 20 to 30%. When compared to a dizygotic twin, الكونكوردنس rate less than 5%. هاي second هو genetic، هو genetics autoimmune. There are in the circulation there are high antibodies against thyroid gland, high titer of anti-TBO antibodies, anti-thyroglobulin antibody, thyroid binding inhibitory immunoglobulins positive, TBII, thyroid stimulating immunoglobulin, TSI. So these antibodies are high in patients and usually positive in patients with a Graves' disease. والحقيقة 80 to 90% they have TBO antibodies. These antibodies helpful for the diagnosis, marker for diagnosis, and for follow-up for remission or relapse. Okay? It helps you in diagnosis and in prognosis or follow-up. Beside to that third point, in patients with relative or patients with Graves' disease or first degree relative at high risk for other autoimmune disease, whether in the thyroid or extrathyroid. In the thyroid, like autoimmune hypothyroidism, Hashimoto's thyroiditis, hypertension, cerebral risk. إضافة للأسالي other autoimmune diseases, pernicious anemia, etc. Environmental factors have been found that citrus is augmenting factor for Graves' disease. Patients with heavy smoker are at risk for Graves' disease higher. And the status, postpartum status in the pregnant woman usually is aggravating factor of Graves' disease. So these are the environmental factors, and I have mentioned the genetic and the autoimmune problem. Okay, now what are the clinical features of Graves' disease? There are features of hyperthyroidism, which is irrespective of Graves' disease or other causes. It is similar, it is present, will be present in all patients with hyperthyroidism, and they are specific for Graves' disease, as you will notice in the coming talk. Now, you see, citrus, smoking, radiation, the neck, medications, infectious organ can cause Graves' disease. Graves' disease may be associated with eye disease, usually Graves' ophthalmopathy and Graves' dermopathy. Ophthalmopathy per se نحكي عليها. Ophthalmopathy اللي تصير عندك sometimes it may antecede or it may follow the disease, or may be coexistent with the disease. It may antecede the disease, or a Graves' disease may occur before the disease appearance by years, or it may follow the disease remission being euthyroid Graves تبقى ophthalmopathy. نعم خلي بالك lid lag أو eye star is not related to Graves ophthalmopathy. Lid lags or eye star occurs in any status in which there is sympathetic overactivity, اللي هي anxious, worried, agitated population. فالهايبرثايرودزم هم عندك كاتيكولامين لأنه التيروسين the same source يصير عندهم eye star, lid lag و eye star لأنه sympathetic. This is not part of Graves ophthalmopathy. Okay? Now, so how does it start, Graves ophthalmopathy? It starts simply gluten eye discomfort and feeling of eye pain, sometimes congestion, and then it will appear specific manifestations: eye swelling or soft tissue swelling. There will be diplopia due to ocular ophthalmoplegia, then chemosis of the eye, congestion of the cornea due to proptosis or exophthalmos, where exophthalmos predominant in 80% of patients, usually bilateral, maybe unilateral in less than 10% of patients, like gynecomastia, 10%, and maybe unilateral, especially in male, as we will see. So these are the eye changes. So ophthalmopathy can be classified into congestive type and paralytic type. And conclusion of exophthalmos or proptosis, you have to document diagnosis of exophthalmos by clinical examination. How do you do testing for exophthalmos? You have to be at the back of the patient, then you have to look to the eyes through the forehead, and this is the way to diagnose exophthalmos. Not standing in front of your patient, you say he has exophthalmos. No, this is wrong. Second, specific testing by exophthalmometer. There is a special test or aid to diagnose specifically exophthalmos by exophthalmometer. This is the dermopathy. So this is very important. The cause of dermopathy, the cause of ophthalmopathy is not related to the course of a Graves' disease. As I have mentioned, it may precede or it may follow the disease. And if you treat the Graves' disease by antithyroid drug or by surgery, you will not treat ophthalmopathy. Ophthalmopathy will not respond. But it may be impaired by treatment by radioiodine radiation of the thyroid gland. It may worsen or it may become worse rather than improve. Okay? Is it clear? So, is it clear?
Yes.
Yes. The ophthalmopathy may progress into loss of vision or sight vision. How? By compression due to edema, periorbital edema, and you can assess the periorbital edema by ultrasound or by CT scan of the orbit, and you may see the optic nerve may be compressed, and there will be, if it is left untreated, there will be optic nerve atrophy. So there will be blindness. So it may progress to blindness. This is one. Second, color vision may be involved. Besides to that, babble edema may occur, visual field may be affected, and as I mentioned, visual acuity may be involved. It depends on which stage you find or you check your patients. At the starting of optic nerve compression, or when the nerve compression has been advanced. The clinical entity will be different. Second, Graves' dermopathy. Again, Graves' course of dermopathy is not related to the course of Graves' disease. Dermopathy occurs in 5% of patients with Graves' disease. The skin changes in Graves' disease consist of the following: hot skin and moist. Why is it hot? Why is it moist? Hot skin is due to hypermetabolism, increased basal metabolic rate. Why moist skin? Due to overactivity of sweat gland, perspiration or excessive sweating. You see, not to memorize, you have to know, you have to understand the mechanism of it. This is first. Then associated, فصار عندك hot skin, moist skin, plus pruritus, plus urticaria, plus hyperpigmentation, plus alopecia in 40% of patients. Reminding you, alopecia may be existent or may remain after bring your patient to euthyroid states by months. You see? So the course of dermopathy is different from the course of Graves' disease. Besides to that, less than 1% patient may have a pretibial myxedema. Pretibial myxedema involving the legs and the feet. What type of involvement? There will be non-inflammatory status, indurated area, and the appearance that of orange skin, tethering skin. So this is what is called, sometimes it is mimicry to elephantiasis. Commonly, maybe bilateral, commonly bilateral, maybe unilateral. This is dermopathy. So this is dermopathy. Shall I repeat, or well-known fixed? Okay. So you see dermopathy. Now the treatment of dermopathy, and I have again I will start with the treatment of ophthalmopathy. Treatment of dermopathy, it is not related, not antithyroid, not radiation, not surgery, not affected by this modality of treatment of the Graves' disease. فهمنا؟ إذا الكورس مالته something else. The only hope for treatment is high potent steroid topical treatment. Sometimes octreotide therapy may be of help. You see, إذا شنو علاجه؟ steroid basement. كأني dermatological lesion عجوة بالكورتيزون. While treatment of ophthalmopathy is different. إذا early طبعا مهمة، وإذا late. الأوفثالموباثي لأنه قلنا أيضا again not affected by the course of ما تعطي أنت ثيرويد ما تستوي، تسوي سيرجري ما تصلح، يصلح الجرافيس لكن هاي تبقى. إذا العلاج مالتها بروتكتيف وكيوراتيف. البروتكتيف هو إذا سيفير إكزوفثالموس تسوي لها ترسرايفي حتى ما تبقى الكورنيال الاي اوبن ويصير كوراتايتس ويصير كورنيال ألسر ويصير impairment of vision. You see, sometimes eye drops, protective, sterile solution, and when there is soft tissue swelling in the orbit, steroid dexamethasone treatment may be of help. Systemic steroid therapy may be helpful. Okay? And in patients, when you come across with advanced neglected ophthalmopathy, قلنا صاير spinal العفو optic nerve compression، شو تسوي له؟ decompression by surgery. Decompression, removal of stretching and pressure on the optic nerve by surgery. And here you need to refer your patient to the ophthalmologist. Okay, to the ophthalmologist. Now, so hyperthyroidism may be or a Graves' disease may cause blindness. The answer is true if left and neglected and untreated patients. Now, ophthalmopathy can occur before, as I have mentioned, after or at the same time as it comes commonly in MCQ. So please listen and concentrate. Early, it may cause sensitivity to light and feeling. We have talked next. These are the pictures, well demonstrating the things that we mentioned to you. You see the clear exophthalmos and lid lag and exophthalmos very clear. Here lid lag and exophthalmos very clear. You see exophthalmos and ophthalmoplegia يسوي دبلوبي يساعد المريض. Especially you have to ask your patient how to assess diplopia. قول للمريض يباع لي فوق ولاترالي upward and lateral. Let your patient move his eye upward and lateral. He will suffer from diplopia. What is the cause of diplopia? Is ophthalmoplegia, paralytic face. Ophthalmoplegia due to weakness of the muscle, due to and soft tissue swelling. You see corneal opacities, advanced corneal opacities and blindness. As you see, these are the picture. Next. Again, you see how far. And by definition, Graves' disease, diffuse goiter, firm inconsistency, and highly vascular organ. You see, diffuse goiter, here, diffuse goiter, as it is written in a clear way, and exophthalmos. Once you see the patient like this, you will say hyperthyroidism?
No, Graves' disease.
What you have to say? Exophthalmos. And then you have to search for the cause, whether Graves' disease or other causes of exophthalmos. Okay? COPD, one of the causes of the exophthalmos. Cushing syndrome may be cause of exophthalmos, and familial may be another cause of exophthalmos. So not necessarily. Be specific during your clinical examination. No, this is a Graves' disease. No, it is wrong. Say exophthalmos and then specify according to clinical finding and examination. And diffuse goiter plus eye manifestation, you will say Graves' disease straightforward. If these are the two pictures are in front of you, diffuse goiter plus exophthalmos, say straightforward the Graves' disease. It's correct in most of the cases. Next. Now, functioning adenoma, as I have mentioned, there are other causes of hyperthyroidism. Toxic multinodular goiter and toxic adenoma or solitary hyperfunctioning solitary thyroid nodule. شلون تميزهم ذولا؟ عادة toxic multinodular goiter, toxic adenoma عادة elderly, age of predilection elderly. Second, usually female. ثم absence of antibodies against the Graves' disease, as we have mentioned. Absence of clue or evidences of autoimmune disorders. ثم presence of elevated T3, elevated T4 and low TSH موجود عند هذا المرض. ذاك الوقت تشخص بيش ثايرويد التراساوند وثايرويد سكان. فاذا ثايرويد راديو سكاننج ايش راح يصير؟ سوليتري نوديول يصير هوت نوديول، البقيه ما تاخذ، فتبين هي هوت نوديول معناتها هايبر فانكشنينج، معناتها راديو ايودين ابتيك هاي. التوكسيك نوديولار دول كل النوديول راح تاخذ الراديو ايودين والبقيه سبرست اللي هي النورمال تيشو سبرست. فبهالطريقه you can differentiate toxic multinodular goiter from non-toxic multinodular goiter وتميز الثايرويد. Now back to hyperthyroidism. Clinical features to hyperthyroidism irrespective of the cause. مو قلنا هسه احنا خصصنا الجريفز ديزيز، حكينا على هاي مانيفستيشن، حكينا على الدرموباثي وعلاج كل وحده منهم وتشخيص، وحكينا على السوليتري ثايرويد نوديول، وحكينا على التوكسيك مالتينوديولار جويتر. الان hyperthyroidism clinical feature or stigmata related to hyperthyroidism irrespective of the cause. إذا كان جريفز، إذا كان toxic adenoma، إذا كان toxic multinodular أو other causes. What are the clinical features? The clinical features that of sympathetic overactivity, catecholamine-like effect due to hyperthyroxemia. يعني patient agitated, anxious, worried, insomniac, loss of memory, concentration. Okay, these are the features. أضاف لهذا the skin, as we have mentioned, hot and moist in hypermetabolism. أضاف لهذا in GI tract there will be polyphagy, and despite of that loss of weight progressively. So good appetite and loss of weight. Plus transit time will be hurry, intestinal hurry. There will be diarrhea. In some cases there will be steatorrhea, and specifically diarrhea occurs at night. It's a more nocturnal diarrhea. Once you hear the symptoms of the patient for nocturnal diarrhea تصير عندي ساعة بالليل، خلي بالك nocturnal diarrhea، مو تقول استبرد مثل ما المريض يفكر، أنت تقول خلي بالك hyperthyroidism. Now in women what will happen من oligomenorrhea and amenorrhea ويصير عندها loss of libido. in man شو يصير مقابله sexual impairment يعني loss of libido and performance plus gynecomastia, usually bilateral and maybe unilateral gynecomastia, and tender. خلي بالك بالامتحانات تجي tender gynecomastia due to hyperplasia of the tissue. Okay, tender, similar to physiological gynecomastia in adolescence. It become gynecomastia لأنه adolescence puberty توصل علاماته and it may become tender. Similar. So the other features related to cardiovascular. فشي يصير عنده tachycardia associated with symptom palpitation, tachycardia, sinus tachycardia, premature ventricular premature beats or extrasystole, atrial fibrillation, SVT, all forms of arrhythmias. Besides to that, augmented angina, ischemic heart disease, besides to that, cardiomyopathy and heart failure. Specifically in elderly population, what is called apathetic hyperthyroidism. Apathetic hyperthyroidism. hyperthyroidism usually subclinical. إذا ما تصير بالكبار أو apathetic subclinical hyperthyroidism يعني not so severe, occurs in elderly. Apathetic patient does not feel of it. نسينا نقول التريمر طبعا part of catecholamine effect أو sympathetic overactivity. التريمر طبعا يصير. And that is for cardiovascular treatment. Increase in blood pressure and wide pulse pressure وbounding pulse وهاي cardiac output failure. هذا الفرق. مو low output hyperdynamic heart لأن basal metabolic rate عالي يصير high cardiac output heart failure, bounding pulse, widened pulse pressure, elevated systolic and diastolic pressure. Okay, hypertension. And when you treat hyperthyroidism, heart failure will be improved. لكن الاترال fibrillation عادة من تعالج الهايبرثايروديزم may revert to sinus rhythm in 40% of patients. البقية يبقون chronic تحتاج لهم another. من يصير atrial fibrillation you can indicate anticoagulant therapy like warfarin. ومن تحتاج atrial fibrillation يحتاج ديجوكسين لازم تعطيه in high dose. ليش؟ Why? You need high digoxin because it cleared easily. لأن high basal metabolic clearance by the liver. So you need to give high dose of digoxin therapy, and you may indicate anticoagulant therapy when there is atrial fibrillation, particularly if it is paroxysmal in type. Okay?
ساعات هم preferable beta blocker.
واحد.
preferable beta blocker.
Yes. هسه بعد سؤال ملاحظ. Beta blocker if there is no heart failure. Digoxin therapy if there is heart failure. Beta blocker given to patient if he is not if atrial fibrillation didn't subside after treatment, or AF didn't subside after treatment. Okay, you give beta blocker with if no heart failure. You give digoxin high dose if there is heart failure. Clear? Clear? Okay. Next. That is all for manifestation of hyperthyroidism symptoms and the clinical, irrespective of the cause, whether a Graves' disease, toxic adenoma, toxic multinodular goiter. Next. 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 Diagnosis. No, sorry. Diagnosis rests on the clinical status plus laboratory assessment. The clinical symptoms and signs plus investigations. Investigations, what you have to investigate? You have to send T3, T4, TSH. TSH is low, characteristically low. T4 may be normal or high. Usually T3 very high. Is very high. Okay, Annie? In all of the cases. And then you assess autoimmune marker or antibodies that I have mentioned to look for Graves' disease and to get benefit for follow-up purposes, to document remission of Graves' disease after that. Now, the blood levels of thyroid hormones can be measured directly and usually by elevated, just a moment, Amir, and usually are elevated with hyperthyroidism as it is anticipated. However, the main tool for detection of hyperthyroidism is measurement of a blood TSH level, and it will be characteristically low in the cases of primary hyperthyroidism, but in secondary hyperthyroidism, in which there is hyperfunctioning pituitary adenoma secreting TSH, it will be very high. So high TSH does not exclude hyperthyroidism. High TSH with hyperthyroidism means secondary type. Okay, clear? Now, there are cases of high TSH, high T3, high T4. In which case, what is your diagnosis? Pituitary adenoma, high TSH, high T3, high T4, secondary hyperthyroidism, and it is mainly related to TSH, secreting pituitary adenoma. Now, as mentioned earlier, TSH is secreted by the pituitary gland. If an excess amount of thyroid hormone is present, TSH is down-regulated and the level of TSH falls in an attempt to reduce production of thyroid hormone. Thus, measurement of TSH should result in low or undetectable levels in cases of primary hyperthyroidism. Okay? Although the blood test mentioned previously can confirm the presence of excessive thyroid hormone, they don't point to a specific cause. You see? Low TSH, high T3, high T4, it gives you a result of primary hyperthyroidism, but it does not give you the cause, whether a Graves' disease or toxic multinodular goiter or toxic nodule or drug-induced thyroid disease, hyperthyroidism, or stroma ovariae. Is it clear? Does not give the cause. If there is obvious involvement of the eyes, a diagnosis of a Graves' disease is almost certain or sure. A combination of antibody screening for a Graves' disease and thyroid scan using radioactively labeled iodine, iodine 131 or iodine 132, which concentrates in the thyroid gland, can help diagnose the underlying thyroid disease. These investigations are chosen on a case-by-case basis. It depends on the case. If you are anticipating or you are suspecting a case of a Graves' disease, you have to look for and you have to investigate for the autoantibodies for thyroid gland, as we have mentioned. Next.
So مثلا بس إذا bronchogenic carcinoma أو شيء تفرز ورات thyroid stimulating hormone. هم راح يصير عندنا TSH high؟
نعم. لا. There are, we will come across this and the subject and the title of malignancy. Malignancy, by far, may be like benign tumor of the thyroid, may be functioning, may be non-functioning. Malignancy, irrespective whether papillary, anaplastic type, may be functioning, may be not functioning. For in functioning, there will be hot nodule by radioisotope scan. If non-functioning, there will be cold nodule. So-called nodule indicate malignancy and indicate hemorrhage. You see how big is the difference. So it depends on the case you are studying. Now, how can we treat the patient? Treatment of the patient is a treatment of the cause, if possible. يعني toxic multinodular goiter, العلاج surgery, or antithyroid drugs for long time. Usually thyroid gland size will persist. تمام؟ solitary thyroid nodule hyperfunctioning يعني toxic adenoma, surgery is بالكتاب هارسن يقال انه in textbooks it is mentioned there is different options. Radioiodine ablation is the treatment of choice, while in other authorities mentioned surgery is the treatment of choice for toxic adenoma. Excisional biopsy is the treatment of choice, and sent for histopathological. Why? Because there is a high chance or high risk of malignancy. Okay, so I have covered toxic adenoma and toxic multinodular goiter. Now, what is remaining? A treatment of Graves' disease. Graves' disease treated by three options. Antithyroid drugs for 2 years, 18 to 2 years, and majority of textbooks it has been shortened to 6 months. Yes, but 2 years, 24 months duration. antithyroid. This is first option. Second, iodine ablation. And third option is surgery. Now, in Europe and in Asia, like Japan, they prefer antithyroid drugs and surgery. In North America, they prefer radioiodine ablation. So there are different entities according to geography. There is different options and different locality. So keep in mind, North America, the option of choice is radioiodine ablation of the thyroid gland and Graves' disease. And in Europe and Asia, Asian countries, they prefer antithyroid drug or surgery. Now, radioiodine ablation is not indicated in young, female, and male, not indicated in a pregnant woman and breastfeeding woman. You see, patients, when being treated by radioiodine ablation, should be prepared to radiation by bringing your patient to euthyroid state. لازم تجيب euthyroid قبل ما تضطر radioiodine. الدوز 5 microcurie وتسوي له سيشنات 6 sessions. زين عيني. الانتيثايرويد drugs to bring the patient to euthyroid states prior to radiation should be stopped 3 days. These are important practical points. Please listen and try to keep them in your mind. You have to stop treatment by antithyroid drug 3 days before you are starting radioiodine ablation. Radioiodine ablation may be associated with elevated thyroid hormones due to thyroiditis, temporary hyperthyroidism, thyroiditis, which may persist for a few months and it fade away. Okay, so keep in this mind. But it may be followed by permanent hypothyroidism, 15% after 5 years. Okay, 15% منهم يصير عندهم hypothyroidism بعد 5 سنوات. و 10 to 15% chance each year past. يعني كل سنة تنظر عليها بعد الراديو ابليشن 10 إلى 15% يصير chance hypothyroidism. وهكذا كل ما تمضي سنين يبدي chance أكثر مال hypothyroidism. These are the radio ablation. البنفيت وأولا choice indication، الشيء الثاني side effect and the way to do the procedure. لازم يصير euthyroid المريض by antithyroid drug وبعدين تسوي you have to follow these meticulous and important points and therapy. Now, antithyroid drugs indicated for patients who refuse surgery and radioablation, indicated irrespective of the age group بالyoung وبالelderly patient والpregnant woman أيضا antithyroid drug indicated. زين عيني. And those who want to shorten the time of treatment because هو المعين الوحيد للعائلة فيريد يشتغل فايش يسوي ما يطول يقدر ياخذ 24 شهر علاج فيريد These are the indication of antithyroid drugs. Now, what are the types of antithyroid drugs? 2 classes, thionamide and carbimazole. Thionamide معناته polythiouracil والكاربمازول نيوماركازول أو ميثيمازول. شنو الفرق بين الاثنين؟ There is very important. البروبيل ثايوراسيل ثيوناميد long half life وعندها peripheral conversion of T4 to T3 high. block peripheral conversion of T4 to T3. So ها؟
رابط أكثر من الكاربمازول.
هاي واحد ولكن لونج اكتنج. هاي مولكيولر وين؟
هذا بالبريجنسي يستخدم.
الفكرة لا يستخدم بالبريجنسي لأنه لس كروس بلاسنتر. كروس بلاسنتر لأن هاي مولكيولر وين فتعبر البلاسنتا barrier بكمية قليلة. زين so it crosses the placenta to the fetus in a little amount. ليش؟ لأن هاي molecular weight. فهذا يستخدموها لأن ما تعبر البلاسنتا قليل هاي molecular weight نفس السبب. ثم عندها peripheral conversion of T4 to T3 توقفها blockade تسوي له وثم عندها long half life ايش قد 6 hours while half life of methimazole or newmarkazole ايش قد 90 minutes 90 minutes. You see the difference. وما عنده blockade for T4 إلى T3. You see, so more peripheral of polythyroxine in pregnant woman than methimazole or newmarkazole. نعم. next question.
بالنسبة لأكو بالثايرويد ستورم يقول إنه يفضلون البروبارثايروسيل لأنه
هسه راح أجيك دكتور. هاي أنت واحدة you are quite correct. وأقول لك الدوز هم.
صار لها علاقة بالتي اس اتش ريسبتور انتي بودي بروبارثايروسين؟
not related. It does not affect the antibodies. It does not affect the autoantibodies. It is fixed and mentioned. TSH receptor antibody is not affected by the antithyroid drug treatment. Very important point. It comes in questions. This is very important. Second, the mechanism of action of these drugs, they inhibit TPO. They inhibit TPO and inhibit organification and iodination. Or in conclusion, they inhibit T3-T4 synthesis. Okay? This is the mechanism of action. Second, propyl or thionamide inhibit the peripheral conversion of T4 to T3. تعرفون T3 10 times more potent than T4. So it is helpful in management. And this is the mechanism of action. عرفنا هسه indication مال anti-thyroid drug. عرفنا mechanism of action. Now what will be the side effect or adverse reactions? أكو transient side effects less than 1 to 5%. 1 to 5%. Should consist of the following.
Agranulocytosis.
لا. Urticaria, allergic like reaction, sometimes diarrhea, nausea, vomiting. These are allergic and transient, and it may fade away. Elevated hepatic enzymes, and it may fade away. The most serious, which constitutes side effect, less than 1%, agranulocytosis or hepatitis or permanent thrombocytopenia. Okay, so hepatitis, thrombocytopenia, agranulocytosis less than 1%. And this agranulocytosis is not dose related, is idiosyncratic. فماكو داعي تسوي له blood count بالفراغ لأنه ما تلقفها لأنه idiosyncratic, not dose related. You see, how can you catch this? When you give your patient antithyroid drugs, you have to ask him to report about fever, sore throat, any mouth ulcers. These are indicative of agranulocytosis. If it occurs, you have to stop antithyroid drugs. بينما اللي صارت fever وارثرالجيا urticaria or allergy or hypersensitivity, it does not, it is a transient. It is not worthy to stop antithyroid drugs, or it may necessitate a stoppage of treatment for a while. Agranulocytosis, it is solid indication for discontinue the treatment. You see, it is very important. والعلاج إذا كانت الجرانولوسايت less than 500 cells per cubic, 500 cell per cubic meter, you have to transfuse your patient with healthy leukocyte. This is the treatment of choice, and you have to search for bacteria if there is bacteria, and you have to give appropriate antibiotic. I have finished with antithyroid drug. I have finished with radioiodine ablation. نعم.
أنت عندك نرجع على غير drug؟
Yes, yes. Yes, you can change, but if the same thing happens, you can discontinue. You have to choose other option from surgery, I mean, or radio ablation. Okay. Now, what is remaining is surgery. Surgery, first indication of surgery, irrespective of the age. It is indicated in young hyperthyroid patients, indicated during pregnancy, indicated in elderly patients. But you have to prepare, again, you have to prepare your patient before to surgery. You have to bring him to euthyroid state by antithyroid drugs. And second, you have to reduce the vascularity of the thyroid gland. As we have mentioned, the organ or the thyroid gland becomes highly vascular area, so it interferes with the field of surgery, with the technique of surgery. So you have to reduce the vascularity. In which way? You give local iodine, 5 drops for 2 weeks in order, or 10 days, to reduce the vascularity, and you have to keep your patient on antithyroid drugs and beta blocker to bring him to euthyroid, and then the patient become operable. Surgery output will be very good, and that's why surgery is the treatment of choice. Now, what are the adverse of surgery or complication? Divided into 2: recent, remote. Complication related to anesthesia, including death, and complication related to the surgical procedures. Temporary hypothyroidism, temporary hypoparathyroidism, and these are the recent. طبعا damage to the recurrent laryngeal nerve and aphonia. This is a common problem in practice, and sometimes bleeding in the field, يعني post-operative thyroid hemorrhage. And then late complications, among them is hypothyroidism, هاي معروفة. Among them is permanent hypoparathyroidism. And these are the common, and you have to keep your patients on follow-up. The type of surgery usually is subtotal thyroidectomy. ليش subtotal مو total? We need the organ, we need a remnant of tissue to secrete thyroid hormone to give the demand. If you do total thyroidectomy, you have to keep patient permanently on levothyroxine or thyroxine. In the next lecture, I will start with